Well, good evening, and thank you for joining me for tonight's webinar, Sticky Situations, Temporary to Permanent Cementation Solutions. Like most of you, I just finished working on patients. I'm on the West Coast, so we finished actually a little bit early so we could do the seminar tonight. So I do appreciate you being on this webinar and joining me. Let's get started. We have a lot of information to get going with. I mentioned to you that I am coming from the West Coast. I'm in San Diego. Hopefully now that everyone is starting to travel a little bit and things are opening up, you can maybe start making your ways out here. We have some beautiful beaches, some different things. That center photo there is of the Torrey Pines Golf Course, which is the site of the 2021 US Open coming up here in June. So if you've never played that course, by all means, I highly recommend it. And hopefully as things open up more, we get a little more travel and start going there. I'm starting to book more courses now in the second half of the year where they're actually live. All right, so a little bit about me, just to give you a little bit of what I do and what I've done. I've been in private practice since 1997. I'm a member of what's called Catapult Group, and I'll explain that in a few minutes. I'm also a CR or CRA evaluator and have been for a long time. This is Gordon Christensen's group. I've also been a director of UC San Diego Clinic, and I'm current adjunct faculty member there. I'm also an editor for Inside Dentistry magazine, and we have CAD/CAM, and we have thousands of restorations placed and lots of things to kind of get information from. So hopefully we'll have a very good webinar for you tonight. I have my email up right here. I do have a lot of information tonight. I'm hoping to get to some questions at the end. If we don't, please jot down my email or take a photo of it. I'm more than happy to get back to you when you email me. If you have any questions afterwards that I don't get to, or you think of something even after the webinar, happy to help always. I'm not very good by phone, but I am very good with email. Also, I am on social media, so if you have an Instagram account, please follow me. I will follow you back. I usually post dental and fun things. I try to keep it away from the political. We got way too much of that around our country as it is. So do give me a follow. And a couple of things. I said I was a member of Catapult Education. This is a group of dental CE providers. Typically on a normal year, there'd be about 30 of us that would be out lecturing over the weekends all over the country on different topics in dentistry. We review a lot of products. We write articles. We have a lot of different formats. There's also a website, catapulteducation.com. If you get a chance, visit that. I have a classroom page there. We have a number of free webinars and some different things that you can look at and learn from as well. I would like to thank tonight our sponsor is Voco. I do appreciate them sponsoring us because without them, webinars like this would not be happening. I do want to mention that as a member of Catapult, I do a number of product evaluations. Some of these products I will be talking about, I am going to be showing you tonight. And I will also tell you that I don't talk about any products that I don't personally use in my office. And I'll explain why I use these products as we go along as well. So like I said, any questions during the webinar, please type them in the question box for now on your screen. I will try to answer as many as possible at the end. If we don't get to them, I will put my email up on the last slide again when we finish. So if you didn't get it, we will put that up one more time if you do have questions near the end. All right, so sometimes good things fall apart so better things can fall together. That little devil on the right has changed a lot of lives in the last year plus since it started. So I'll give you my own personal story and what happened with our practice. We were shut down for about 2.5 months. So it was an interesting world back then. And even when we came back, some of my team members did not want to come back. So we actually turned over a good amount of our team, probably about 80% of them. But I will tell you, since we did that, we had a monster year in 2020. And I actually believe that we actually improved every position in our team by changing them. So sometimes maybe things do fall apart so better things can fall together, because I really truly love my new team now. And I hope you have had similar experiences. Hopefully you haven't had any tragic experiences. I always like to think whatever doesn't kill us will make us stronger. So hopefully you're all having good experiences with it and that your practices are thriving and doing better now since that. coronavirus. But anyway, as we move on, let's talk a little bit about what our webinar topics for this evening. I'm going to just briefly discuss, and I always do this in most of my topics because I truly believe in the importance of isolation and how it can really affect what we do in the dental office. So I'll spend a few minutes on that, just share some studies and some different things with you there. We're going to talk about advantages and disadvantages of indirect restorations. Most of what we're talking about today is going to be cementing indirect restorations, whether it's temporarily or permanently. So there are advantages and disadvantages to both, and we'll discuss those a little bit so you can kind of pick out which you decide to do, whether you do decide to do indirect or direct restorations. We'll talk about options for cementation. Now, I know this is a 1-hour webinar, so I'm going to try to bring in as much as I can in terms of we'll try to go through 2 or 3 different types of cementation processes and let's see how far we get along. And cementation protocols for zirconia and Emax, those are the 2 most popular restorations out right now. I will show you why they're the most popular, how much they're being used, and we will also discuss the protocols for cementing each with the different cements. We will also try to touch up on some temporary cements near the end there as we go through. And then I will discuss some tips for avoiding mishaps. I'm always happy to share mishaps that I've had so that you can have less as you grow and learn and practice in your dental offices. So I always like to put this slide up as well. There is more than one way of doing things. And by all means, please don't think that what I'm teaching is the only way of doing things. Sometimes you may disagree with it, but at least it'll make you think. And if you agree with it, that's great. Take what you like and modify it to fit your own practices. Sometimes when we see things being done by other people, we tend to learn a little bit from them and we can pick out what we like and don't like. And that's exactly what I want you to do with this webinar. My philosophy of treatment has gotten more and more conservative as I go. I think that teeth should be treated with the most conservative restoration available to satisfy the patient needs for aesthetics and functions. I do more inlays, onlays, veneers as much as possible. Granted, when you're doing indirect restoration, sometimes you have to replace crowns or things like that. Then you have to replace them, and that has to replace with a crown. But I try to be as conservative as possible and always thinking with the end in mind. So try to begin with the end in mind as you go through. We're going to talk a little bit about indirect restorations first before we get into the cements. So that's where we're going to be using a lot of the materials and things that we're going to be talking about. Isolation and technique sensitivity is first here when we talk indirect restorations. So things like isolation, whether to etch or not. How long do you etch for? Dry but don't desiccate. That's always an important one. A lot of these things can cause some of the sensitivities we tend to find in practices, whether we're cementing or whether we're doing direct procedures. Also things like curing time, distance from the composite, and others. So this is kind of a sensitive area where we need to talk about it and make sure what we're doing is correct. So I'll go through this process in a little bit, but one of the biggest things that I like to discuss is that top one, that isolation. Ever since I like to put this study up, and it's an older study, it's been around since 1995, but basically it states that contaminants lowered the bond strength by 20 to 100%. We've known this for a super long time. If you don't have a dry, isolated field, and keeping the tongue, saliva away, and sometimes even the moisture from breathing, your bond strength is decreasing. This is one of the reasons I harp about any restorations, whether you're doing them direct or indirect. So we've known this for a long time. I hope that you are all getting into some form of isolation whenever possible. There are different formats. I know that CRA always ranks the rubber dam as number 1. It's also the least expensive. A lot of people aren't big fans of the rubber dam. I will tell you, we don't use the rubber dam all the time. We do at times, but a lot of times we use something like Dry Shield, which is like something that in the lower right picture there. But rubber dam is pretty easy. If you want to use that, show your team members, have them watch a YouTube video, have them learn how to place it. You can numb the patient, have a team member go in there, get the rubber dam on, and you'll be able to work without saliva, the tongue, or anything. It'll be great to work on. Things like Otrigate on the lower left are great when you're doing indirect restorations that are larger cases, or if you're doing attachments for Invisalign, things like this. But my favorite and what we use mainly is something like an isolation shield, a dry shield, which I'll show you in a minute. I do want to show you the study here that was from CR in May 2019. It shows all of these isolation products. So it lists the product names up here at the top and which company they're from. It gives you cost per operatory, so how much it's going to cost you. Some of these products you can actually move from operatory to operatory. It also gives you the cost for mouthpiece. You have to remember some of them may be autoclavable and have multiple uses. Like this Dry Shield one, they also currently have a non-autoclavable or a disposable one as well. It tells you what kind of systems you need to use, how many mouthpiece sizes, how many options there is for it, whether they have illumination or not, whether there's lighting involved with them or not. I would assume that most of you have loops that have lighting on them already. So if you do, typically that makes this kind of a non-issue and non-needed and one less expense that you have to deal with. And then it talks about the retraction and isolation, whether it's retraction in the mouth and all the other things. So this is a good little study to look at. It gives you an idea of what they are, how much they are, and what they cost you. The one that I was talking about was something like a Dry Shield, which allows us to really increase efficiency and productivity because it allows you to work on both quadrants at the same time. The great thing that I love about it is that I don't have to worry about the tongue and have to pull the tongue back, and my left hand isn't usually hurting by the end of a procedure if you're working against somebody who has a strong tongue. And also that the assistant doesn't have to worry about retracting the person because this retracts the cheek. It retracts the tongue, keeps it away. It is sucking up saliva because it's on a high-speed evacuation. These pieces are autoclavable. They also have disposable mouthpieces as well for single use. It really increases visibility. It allows the patient to bite comfortably down on one side. And it installs in seconds. Our patients have really gotten to know it. They're like, oh, are you going to use that thing in my mouth? And some of them are like, yeah, I like that thing because it takes all the saliva out. It keeps me open. I don't have to worry about trying to stay open because it allows them to bite down on something. And they are portable, so they can be moved from room to room, but we basically have them in every operatory. Even our hygienist uses them now. So makes their lives a lot easier. And if my assistant ever gets out or needs to pick up something, I literally continue working. So I really don't stop at all when we're using this. Now let's discuss a little bit of indirect restorations here as we go through. First, you have to evaluate the case. Hopefully you're not getting too many cases like this. And obviously we don't have enough time in this webinar to discuss what to do with a case like this and how to start it. But we are going to want to evaluate, especially when you're doing single units or you're doing quadrant dentistry. Do plan out your case. You want to look at the case, you want to evaluate it. Photos are always great. We tend to take photos of all our new patients when they come in, so we have an idea of what we're looking at and what we're working with. Even when they're not here, we can prepare for them sometimes if they're a more complex case. Will the case be done using impression material or scanned? We have both, and we tend to scan most of our cases, but we do have both. Sometimes some cases do require impression material. So will the case be done in the office or not? Is this something that you're going to do in the office, or is it going to be something where you scan it and send it to a lab, or take an impression and send it to the lab? Check the patient's bite before prepping. I'm going to talk about this a lot, and I'll show you when we go to show clinical cases. I always like to check the patient's bite before we start. Typically, I have my assistant have the patient bite down on articulating paper and go from side to side. I want to see where they're biting down when I'm going to make my prep, whether it's a direct or indirect restoration, because I want to leave my restoration in an area where they're biting on it either with all on tooth or all on restoration. I don't want them biting down on my margins because that will cause my margins to break down and it will make my restoration last a lot less than it should. Okay. Now, determine where the margins will be, and that's what this is going to help you, because you're going to figure out where you want to place them after you use articulating paper and which materials will be used. This is a big thing that we're going to talk about here as we go through. So indirect restorations tend to have many advantages. They're great for controlling form and surface. They're really wonderful when you're doing multiple units in the mouth. We actually have done full mouth cases in a day. and actually had where you have one patient and you're basically working on them the entire day. And I have a lab tech also come in so they can help us out in getting these restorations in. But I'll tell you, most of the time, I like prepping the cases, temporizing the patients, giving my lab the time 2 to 3 weeks to actually get the case all set up and ready. But it can be done in one day as well. There are multiple materials to choose from, and we will discuss materials as we go along here. It really gives you more time to do with the multiple teeth and how you want to restore them and what kind of things you want to do. And sometimes as you're trying to do many things in one day, you can run into problems with tooth color or some, decay that may extend below the gingival tissue. They do allow you to have excellent longevity, and the color stability tends to be excellent with indirect restorations as well. Now, what are some of the disadvantages to indirect restorations? They usually require more tooth preparation versus direct restorations. And usually you really need very good lab communication, unless you're using in-office fabrication where you're doing it CAD/CAM yourself in the office, then basically you're the lab. But if you're not and you're doing some cases where there's multiple teeth, you really want to have great communication with your labs and be able to give them photos as well, as many photos as you can, so that you can give them as much information as possible and they can give you a great restoration back. The more information you give a lab, I always feel like the better the restorations come out. Sometimes these can require high skill of seating, sometimes veneers, and those take a little bit of time. And if you have a good process where you're doing them from A to Z, then it becomes much easier, but they can require a little higher skill in seating them. Also, repair is not the easiest. A lot of time these porcelain materials and products are put together in ovens under heated situations. So sometimes when we try to fix them in the mouth, and I've used a number of different porcelain products to try and repair them, and I haven't really found one that I truly love. There are some that work okay depending on location and how much porcelain is broken off. Now, let's talk about choosing the material. Prep the tooth for the material you're replacing, or you're placing actually. Are you just replacing enamel? Is this going to be like something where it's a super thin veneer, like the 0.3 millimeter Emaxes that can be done? Well, if that's the case, then you know what your material is going to be. Most likely it's going to be Emax. Empress tends to be a little bit thicker when you're trying to place that, but that's a very nice material as well. Are you replacing enamel and dentin? Is it a normal colored crown where it's going to be as simple as you can choose whatever you want? Or is this a dark colored crown where maybe you're going to need to choose a zirconia or perhaps a PFM to cover that? Or is this something where you want to try to fix the dentin and the discoloration before you actually take your photos and try to get your final restoration to it? So think about prepping the tooth for whatever you need. This is a materials table that I always like to list and show in my courses. It's going to talk about a couple of things. Here on top, it's going to discuss minimal prep veneers or veneers, anterior crown normal prep, anterior crown dark prep, anterior crown short prep, anterior bridges, posterior full crown, and posterior bridges. On the left side, it's going to talk about the different materials, and I'll discuss those as we go through. The more pluses, obviously, the more likelihood of using this type of material for this kind of a situation. And X means typically that you don't want to use this material in this type of a situation. So let's go through some of these, and we try to simplify this as much as possible to try to keep it simple. But we'll start with powder and liquid. Those are the old feldspathic porcelains. For those of you who had done some of those, they are beautiful. I have lots of feldspathic porcelain in my patient's mouth, and they look great. Unfortunately, it's not a procedure that's being taught to too many lab techs anymore, and it's definitely not something that too many labs are doing, especially with the advent of Emax, because Emax made it a lot easier because of the material strength and how nice it looks when it is used. But this was a beautiful material. It wasn't very strong. It was only 80 megapascals strong. So in the anterior section, it looked pretty good. Maybe not something you'd use ideally on a dark prep tooth because you could really see the color of the tooth through it. But in the posterior, this wasn't something you'd want to use in the posterior. That's the reason why I have all these X's on there. Next one are pressed ceramics. These are things like Empress Authentic. For those of you who still use Empress, perhaps, because it is a beautiful material. I have Empress in my mouth, and I've had it there for over 15 years, and it looks great. Obviously, in the anterior, it's very, very good. In the posterior, not as great, although even some premolars I've had it on, and it's worked pretty well. The strength of this is 125 to 170 megapascals. So that's a little bit stronger. You know, it's basically more than twice the strength of the powder liquid. So it obviously gained some momentum there for a while, up until lithium disilicate, which is Emax, came along. That can be from 360 to 400 megapascals strong, 360 for those of you that do CAD CAM in the office, about 400 for those of you that do the lab ingots and sending it out to the lab. This material is beautiful. It is strong. It is very, 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 it looks great. It's very aesthetic. As you can see, I listed pluses all over the place here, except for posterior bridges. It is an Ivoclar material. They recommend that you only go as far as the first molar and that you not have bridges more than 3 teeth, especially posteriorly. And so if you do use it, make sure you are careful where you use it for posterior bridges. The next item we have is going to be zirconia. Now I have zirconia from 600 to 1400 megapascals strong. Obviously, the biggest example is Bruxer, but I will talk about some others here in a couple of minutes and discuss why some of these strengths are from 600 to 1400. Some of the more aesthetic zirconias aren't quite as strong as the 1400 megapascals of Bruxer. And to be honest with you, I don't know how often we need a 1400 megapascal strong crown. Maybe some patients, but the majority of patients probably don't need that kind of strength in their mouth. How often are they taking a hammer to their crown? Hopefully not too often, but it can withstand that. So it is very, very strong. Now, I will tell you, I used to not have very many pluses in the anterior on zirconia, but they are starting to become more and more aesthetic. Especially the layered ones, as we'll talk about here below. But even the monolithic are starting to look a little bit better. Obviously excellent for posterior crowns, very good for posterior bridges. And it's being used more and more in the mouth, and less Emax is being used, as the numbers will show, and I'll show you some statistics here soon. Let's talk next about zirconia-based type products. Now, we only have them as 80 megapascals because anytime you have more than one product where it's not monolithic anymore, where you have zirconia as the base, kind of like lava, for those of you that remember lava and have used lava in the past, where the zirconia is on the bottom and then porcelain is placed on top. Well, anytime you have that, even like a PFM, the strength goes down to 80 megapascals because it's the porcelain that tends to chip off and break, not the metal or the zirconia that's underneath. So obviously that's not used for minimal prep veneers or veneers, but anterior crowns and all over the other places, it does look very good. It's had some pretty good success. I know some people have told me they've had some issues with the lava in the past, and some of that was lab and things like that. But overall, these have had good success, even with the strength at 80 megapascals. Another item is the next or last item, I should say, that we're going to talk about here is the PFM crowns. These are also going to be placed at 80 megapascal strong. Now, I know they have a long, long history. I have pluses for them all over the place. They've looked great for a long time. It's only 80 megapascals because, again, you have two items that are coming together, and that's the metal and the porcelain. And so where the product tends to fail at times is when the porcelain chips off. The metal is rare, if ever, that's going to break. And that's the reason why we have it at 80 megapascals. So this material table gives you an idea of some of the products, where you can use them, where not to use them, and you can keep that in your head. Now, we spoke about a couple of products that do pretty well in there, and why are Bruxer and Emax doing so well? Well, in this study, this was a study done by Dr. John Burgess back in 2010, and it was presented at the AADR meeting in Washington, showing how close to enamel Bruxer and Emax do wear. Their wear compatibility is very, very good, which is one of the reasons why we started using them more often. I'll show you another study here that shows the low enamel wear. Why zirconia? In this study, it shows the enamel wear of it shows the wear of enamel to enamel and also zirconia to enamel. If you look at this, and this was a study that was done in operative dentistry in 2014, you can see that zirconia to enamel tend to wear even better than enamel to enamel, which is another reason why we like this. Now you have to make sure the zirconia is polished or glazed, but these are some of the reasons why these products started becoming much more popular. And this, I think, is one of my favorite studies. This is also from Dr. John Burgess out in University of Alabama. This shows the crown fracture strength in newtons. Now, let's talk about this a little bit. We're going to start over here on the left. This is a 1.5 millimeter PFM. So this is a normal prep PFM. The fracture strength of this is 2284 in newtons, okay? So that's a normal prep PFM, 2284. Now let's do the same thing for an Emax. This is a 1.5 millimeter Emax. The fracture strength of that is at 1863 newtons, okay? Let's take that one step over to a layered zirconia. This is not monolithic, this is a layered zirconia, okay? So how strong is that? Well, that's 2308, so that's a little bit stronger than a PFM for a layered zirconia. Let's take it over now to monolithic. If we're at a 1.5 millimeter zirconia prep, look at what that does to the fracture strength. 4109, it almost doubles a 1.5 millimeter PFM or a layered zirconia and more than doubles the Emax strength. Now that's pretty strong. So then we say, okay, well, if that's pretty thick, we can prep a little bit less. So let's see what happens when we prep a little bit less. At 1.2 millimeter zirconia prep, it's 3068 fracture strength. It's still stronger than a PFM or an Emax or the layered zirconia. Well, let's prep a little less. Now we're being a little more conservative. A 1 millimeter zirconia prep still gives you better crown fracture strength than the Emax or a PFM. So this is kind of the favorite in here of why we like zirconia. It allows us to prep and be a little more conservative, and yet the strength is still there. Now, if you go even less and you're reducing your zirconia to 0.8 millimeters, it's at 1814, and at 0.6, it's at 1308. So keep that in mind as you prep. This does allow you to be more conservative, remove less tooth structure, especially as people are living longer. We try to give them smaller preps, more conservative, so that we can continue the life of the tooth further and further. I told you I would share some numbers with you, and this is information from Glidewell Labs as of 2020. So this was for the year 2019 through 2007, okay? Well, we want to look, there's a lot of numbers here, but just focus in on this section where the blue numbers are. And we'll look up here at PFM. In 2007, they were doing 65.3 PFMs. In 2019, they only did 8.6%. For all ceramic, in 2007, they were doing 23.9%, almost 24%. In 2019, they're doing 88.9%, almost 89% of the restorations they do in that lab. And that lab is one of America's largest labs, if not the largest. They have dentists in every single state of the union. So we get a pretty good crosscut of what's actually happening in the entire country and where the restorations are going. Full cast, for those of you who still prep gold and do it, in the year 2007, it was at 8%. As of 2019, they only do about 2.2%. So it kind of gives you an idea of where we're going in the industry and how it's moving. Now let's talk about lithium disilicate, which is Emax. This was an Ivoclar product. Like I said, it was about 360 to 400 megapascal strong. It started in 2005. I don't know if many of you remember Empress Eris. That had started before that, and that was a lithium silicate. It didn't do quite as well as this lithium disilicate. This has been quite a home run for the Ivoclar because it's worked very, 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 very well in single units, anteriors, posteriors. They look beautiful, and veneers as thin as 0.3 millimeters. Now zirconia. is, like I said, 600 to 1400 megapascal strong. There's some different types. Bruxer is not the only one. There's Xenostar, Haney, and many other brands of zirconia now. I also put up here the reduction values if you'd like to place for zirconia. It also talks about feather edging the margins. That's a little hard to do unless you're have experience with that. Be careful with that. You can always do a chamfer in there as well. So, but a 1 millimeter zirconia prep, I call it my 1 millimeter rule. If you go all the way across 1 millimeter across the occlusal, the axial, that typically keeps you out of trouble and gives you enough material to be strong, as we saw in that study, and be conservative as well. So keep that in mind as you go through. These materials also cost less, which is, I think, another reason why we started moving towards them. I'm going to show you another study or two, which will show you why we started moving towards them as well. But they do cost less than metal. So I think that's another reason why many dentists started switching and moving in that direction. Here's a marginal fit study. This was from CR Report, March 2015, that talks about zirconia and the marginal fit of zirconia versus complete metal and some of these other restorations. It's at 36.6 microns there. Complete metal, which is a gold, is 37.2 in this particular study. So the margins there are just as good, if not a little bit better than gold. If you look at things like Emax is at 55, PFMs are at 64.3. To give you an idea, a human hair is about 100 microns, and a clinically acceptable margin is 100 to 120 microns. So you can see by this study as well why we started kind of shifting towards zirconia. Preparation, I just want to give you a little advice on preparation. Try to keep it as simple as possible with a minimum number of burrs. I try to use one occlusal reduction burr. I typically use a 330 burr. I try to measure them. If it's 1.5 millimeters, then I'm pretty much going to be open to doing any restoration that I want. If this is a tooth that's had a lot of wear, things like that, I may get a 1 millimeter burr and use that as my depth cut to do zirconia with. But I try to keep it to 2 or 3 burrs at maximum. Basically, I'm doing a preparation burr. I'm doing a depth cut burr, and then I do this preparation burr right after. And most of the time, that should take care of it. If you'd like to smooth out your margins and walls, that can do it as well. You can use another burr, maybe a red diamond in there, and just go in and smooth it out. But try to keep it minimum. I have seen other people, I've been to offices, and they sit there and they change like 5-6 burrs throughout a procedure. You know, keep it simple, keep the procedure moving. That way you're not taking too long going back and forth between restorations. Okay, so let's talk a little bit in terms of cement options. We've talked about the indirect restorations. We've talked about some of the different things we can do with it, how to use it, some of the different materials, where to use them. Now let's talk a little bit in terms of cementing options. Let's start with permanent cements here. And there is a couple of ways we're going to go with this, and I'm going to share with you what we have today and what type of cements that we typically have out there. Now, the resin with adhesive system is the strongest cement we have. So this is in decreasing bond strength to tooth structure. Zinc phosphate is obviously the least and weakest. Although one of the things that I'll harp on and I'll really talk about is how prepping is really a big factor in what cements you choose. And we'll really discuss that as we get to my tree of cementation near the end. But preparations really dictate cements and what we can use and what we should use. The larger, the longer the preps you have, the better axial walls you have, the better degrees of taper, the less strength of cement you're going to need. That's why at times, have you guys ever cut off a crown that's been on, a patient shows up and they say, oh, I've had this crown for like 40 years, and you cut it off and it has zinc phosphate underneath it. Well, zinc phosphate is not a very strong cement. I always laugh and jokes and say that zinc phosphate has the holding strength of chewing gum. But all you need is just something to seal the tooth when you have great walls and you have very long, nice preps. So keep that in mind as we go along. But anyway, in permanent cement, so you have resin with adhesive system, you have resin self-adhesives, and then resin reinforced glass ionomers. I will tell you, these top three are the majority of what most offices use, probably like 97% of the time. And so I'm going to try to tackle the top two, which are the most used in there. Resin reinforced glass ionomers are a very good cement class as well. Basically, they don't strengthen your restoration if you put them in there. Those are basically used on if you have a very good prep and you don't need any extra strength from your cement, then a resin reinforced glass ionomer is a great cement to use in that case. It's real simple. They tend to release fluoride and they keep you out of trouble, and you don't have very much to deal with in terms of sensitivity or having to use adhesives, etc. And we'll go through that again near the end when we get to the cementation tree. So let's start with the strongest cement. This is a resin with adhesive cements. These will give you the highest bond strength you can get. It's also the most retention and strength a restoration can possibly have. So where you want to use this is in areas where you basically don't have a very long prep or a very good taper or things like that, where you need that extra strength from an adhesive cement to help you out and help you keep that restoration on that tooth. Most of these systems tend to work with total etch, selective etch, or self-etch. They're also typically dual cure systems. And they cover an entire spectrum of indirect restorations, typically on most of them, depending on shading and things like that. Now, the biggest caveat I have to tell you about this is you do have to be careful with technique sensitivity when using these cements. And we'll talk about that as I show you some examples here. So the resin cements with adhesive systems can be worked with self, selective, or total etch. You create a hybrid layer. Basically, you're cleansing, silanating, and inserting. There are many options out there. There have been many cements and more come out. It seems like every day there's a new cement that comes out and touts itself as being the best. So I like to talk about Bifix QM. This is a Voco cement. It's a dual cure resin cement and has been around for over 10 years, more like 12 years. There's 10-year studies on it, so it's been around the block. It's been there. It's a long-lasting cement. It's very easy to use. You can use it on anything from inlays, onlays, veneers, crowns, posts, etc. Can be used anywhere in the mouth. It's had 10-year clinical success records, super easy to clean up, great color stability, and it also works wonderfully with Futura Bond U, which is an adhesive that I'll talk about in a moment as well. But this is a cement that's been around for a long time, and that's one of the reasons that I like it. It's got a lot of history to it. We know the dependability. We know how long it's been. It's gone through a lot of things, not like a lot of the cements that are out today that keep touting, oh, this is great. Well, let me see a study, and there's no studies on them. So I'll talk a little bit about cementation protocol here with Emax and lithium disilicate. When you're working on the tooth surface, actually, let's talk about the ceramic internal surface first. So you're going to etch with a hydrofluoric acid. This can be done at the lab or in your office if you do CAD/CAM. And then you're going to silanate it chairside, and then you're going to cement with a light cure or a dual cure cement. Now, the tooth surface itself, you can etch with phosphoric acid if you're using total etch or selective etch. And if you don't have to use it, you don't have to etch at all, depending on which system you used. And then you can rinse and apply a bonding agent. Let's show you a CAD/CAM clinical restoration here. This is a fractured crown, tooth number 28. Patient came in, they broke this crown. So I always I talked about this is articulating pre-op to see where the patient is contacting, what's going on with it. As we look at this tooth, one of the things that I noticed is perhaps that distal lingual wall was a little bit thinner than we'd like for it to be. So I always look at why things broke to try and get an idea of what I can do to help mend that and not have the same situation come back and bite me. So that was one of the things we did. So as we go through, we clean up the tooth. We always use isolation in all of these restorations, things like dry shield, etc. We also use a laser for gingival troughing. I tend to use that a lot. I try not to pack cord too often anymore. I just find it takes too long, and sometimes you can damage gingival tissues and you can have different things with it. I find it's very simple to just go around and do some gingival troughing with a laser. And then you're going to go to your restoration. So we have hydrofluoric acid, which removes the glassy matrix. 20 seconds only on Emax restorations, especially if you're going to do this CAD/CAM in the office, or if you've tried this in and you feel like you need to go in and redo it again. You want to use only 5% or less strength of phosphoric acid on Emax. This comes from Ivoclar directly, so you don't want to use anything stronger than 5% and only for 20 seconds. Once you rinse that and dry it, you're going to use a silane coupler. And the reason we use silane couplers is because it promotes chemical bonding to the ceramic. That's placed in there. You leave it in there for 60 seconds. You air dry it if it doesn't dry up by itself. I love using a warm air dryer from ADEC. Those things are great. There's no water with them, so it's just pure warm air. If you have ADEC chairs, by all means, try that out. It's a great thing. But this does, silane coupler can add up to 20% to your bond strength, so that's an important thing to do. Once you have those ready, you're going to go to the tooth, you're going to clean etch, place your adhesive, and then go ahead and place your cement onto the tooth. Now, I talked to you a little bit about FuturoBond. This is an excellent adhesive, super fast and easy. 35 seconds is all the time this is needed. Basically, you apply it, you dry, and you cure it in 35 seconds. With this adhesive, there is virtually no post-op sensitivity. This is a great part of this adhesive. You basically eliminate post-op sensitivity. As long as you're using isolation and use this, it works fantastic. 39 megapascals of adhesion to dentin and enamel is very, very good. Among the tops there. Self-etch, selective etch, or total etch mode, whichever you'd like. And the best part is using these single dose applications, which allows it to always be fresh. You don't have to worry about the solvent evaporating from the bottles, or if your assistant maybe left the bottle opened and it's not working quite as well as it should, and you won't know that for a few months till things start to kind of falter and fail a little bit. So I do like these single dose applications. It bonds to all light, dual, and self-cured materials, and to all materials, whether it's metals, zirconia, aluminum oxide, silicates. You don't need any additional activators as other adhesives and cement processes can. You can use it on any direct or indirect materials, so composites as well as crown and bridge, and it doesn't require refrigeration. So some great pluses behind this material. Has been around for a while too, so it has some great studies behind it. Again, once you seat the crown with cement, it's seated on the tooth. You can wait until the doughy stage and then start to remove the material, or you can light cure for 2 seconds and clean up. And about an hour and 30 minutes later, since this is CAD/CAM, you get a restoration like this. You get a nice Emax restoration in there. It's going to be much stronger and should last that patient much, much longer. Notice I kind of went a little bit heavier on the distal lingual to give them a little more thickness there. And also spoke to the patient about getting a night guard, because you can see some of the incisal wear on the patient's teeth, and that's another thing that needs to be looked at as well whenever you're evaluating the patient's bite and everything else with them. So now let's talk about cementing with zirconia restorations with this type of an adhesive cement, with a resin adhesive cement. Let's say this was a zirconia type restoration. I'm going to give you the step-by-step here at what you would do. You would try the crown in the mouth and make any necessary adjustments to the contact, etc. Okay? After that, when you're ready to start cementing, you would take it and you would sandblast the internal surface of the crown for about 15 to 20 seconds at about 15 psi, okay? Or if you don't do that, you should at least use a scrub Z-Clean, which is a Bisco product, or IvoClean, which is an Ivoclar product, inside of the restoration for about 20 seconds, and then rinse and dry these, okay? These are going to kill some of the phosphates, give you a similar type effect to that of sandblasting. Then after that, you would place a zirconia primer on the internal surface of the restoration for 20 seconds and dry it for 3 to 5 seconds with an air syringe. On the tooth, you would etch, rinse, and dry. Keep it moist. You don't want to desiccate the tooth. Desiccating it can cause some of the sensitivity that we talked about, and then treat it with the adhesive. And then mix and place the cement in the crown. Seat the crown on the tooth, and then proceed with cleanup, or wait for a 2-second light cure, and then go ahead and clean around that. So these are the steps that I recommend for cementing zirconia with a resin adhesive type cement that's a dual cure cement. Okay, so now let us discuss the next class of cement, which is a little bit weaker than the class we just discussed, but this is a resin self-adhesive cement, okay? These are quite a bit time savings because there's no etching or priming or bonding, basically. I know a lot of people like these. Just know that you're not getting quite the bond strength as you're getting with a previous class of cements, okay? I know people like them because they're fast or quick, and in the right situation, they do tend to work well, and we'll talk about those situations here in a moment. There is virtually no post-op sensitivity with this type of a material. So, if you're not worried about, if you have an area where you have maybe you don't have good isolation, and you do want a little bit of moderate strength in your cement, this would be an ideal cement for you. They're strong, they're moisture tolerant, they do strengthen the restoration moderately. Again, not as much as the previous class of cements, but they do strengthen it moderately. And they are very, very easy to use. There are many choices of these the resin self-adhesive cements. And obviously there are many out there. You each have your favorite. I do like the Bifix SC. Again, has been around for a very long time. It's tried and true. This is a dual cured self-adhesive resin cement. My favorite thing about it is that it has a very low film thickness. It's only 10 microns. It's very, very easy to clean up, whether you use a gel phase or a 2-second light cure. But the 10 microns allows it to seat nicely, and not make the restoration go higher. Sometimes some of these different resin cements tend to be a little thicker, and sometimes you have tried your restoration and then you go and cement it, and all of a sudden it's a little bit high. Well, sometimes it's the cement that does that. So having a low film thickness cement is an excellent thing to have when you're placing some of your restorations. It does have an endo tip for easy post cementation. Also comes in 3 shades: transparent, universal, and opaque. Let's take a look at this clinical case, and I want to teach a few different things as we go through this case. Patient presented with a missing tooth number 30. The crown was swallowed. There were no carbs involved. But the patient did come in and show us, hey, I lost this tooth. And of course, I mentioned, well, how about we change this tooth too? They say, no, just fix the one that's gone. Don't worry about that one. That one's just fine. So you say, okay. So let's look at this tooth a little bit. And this is probably one of the most important things and one of the most important slides I can show you. And I highlight this, and if I could have fireworks shooting out at you in your computers, I would have this be shooting out right now. But the most important factor in cementability is the amount of remaining tooth structure, resistance and retention form of the preparation. Those are the really important factors. It's not always, which cement? Let me put the biggest cement. Think about your preparation first. Think prep first. The prep really guides and leads the entire process here. For a monolithic zirconia, I wrote it in there, 0.5 to 1 millimeter chamfers or rounded shoulders. You want 1 millimeter, 1.5. If you want clearance, a lot of times when we put 1.5 for a zirconia, we know that sometimes we may be adjusting, and that 1.5 could wind up going down to 1.0. So a lot of times I do recommend people prep more than 1 millimeter in case there's going to be adjustments to be made. Once you adjust, you don't want to go below 1 millimeter because you like that strength in the zirconia. Ideally, 4 to 8 degree taper. You'd like 4 millimeters plus axial wall height. That's not always possible, and that's why we have to think about which cements we want to use depending on the case and the situation that we're going through. So let's take a look at this. As the patient comes in, I have them bite down. Would we just place a crown right where it is and where these margins are? Because if we did, becomes a short clinical crown. You don't have that much clearance in here, so the thickness of our material is not going to be great. So there are some things we want to do, and look what we do here in terms of the prep. Look at our axial walls, look at our clearance. All of a sudden, we gave ourselves much more room, gave us much more stability, and are able to now place a crown on there that's probably going to last a much longer period of time, if not forever, okay, with these type of walls. And having these kind of walls allows us for much better choices in terms of cementation. So those are the things you want to think about, okay, and process in. think about your resistance and retention form of the preparation. Those are truly important. Now, monolithic zirconia is good over probably 80% of molars. I don't tend to use it everywhere in the posterior. I still use Emax at times because I do like the aesthetics of Emax a little bit better. But when I need it and I need strength, I will go to monolithic zirconia in the posterior. Adjustments are similar to lithium disilicate. That's what the LIS2 means. And the prep is 0.5 millimeters less aggressive than the lithium disilicate or Emax. These can be cemented or bonded in place. Just know that when you bond them, it increases the adhesion, but you need better isolation to do that. The reason I say that is the last thing you want, and if you guys have ever had this, is you go to prep a tooth on a patient that had no pain, and then all of a sudden they come back to you and say, I had no pain before you did this crown, and now I have this pain in there. A lot of times I can go back to either isolation issues or perhaps your bonding technique that may have caused that sensitivity. And I know that's like a punch in the stomach when a patient says that to you, and it's the one thing you want to stay away from. So that's why I try to guide you in terms of which teeth to really bond and which ones to not. If you don't have great isolation, we don't want to bond the teeth in. And then this would be kind of an ideal type of cement to use, a self-adhesive cement. So we put it in there, we check our contacts. When you're adjusting zirconia, you should use a finishing diamond, a concentric burr, light pressure, and lots of water. Make sure of that. And then also, once you go in, I'll show you this slide, and then I'll show you the next one about polishing. So the minimum thickness to maintain full strength of zirconia you'd like ideally is 1, but minimum can be 0.5. That's why whenever you prep a 1 millimeter type zirconia, if you wind up adjusting a lot, remember you're losing some of that thickness and that strength. So your fracture power goes down as well. And that helps you prevent, and to prevent breakage also, do not adjust the bridge connector areas in those as well when you have some of those bridges. Adjust solid zirconia restorations using a fine grit diamond. Very light pressure, and try to use water with that. This helps you avoid microfractures in it. And then polish using zirconia or porcelain polishing kits. If you are getting hand polished zirconia and you adjust it, by all means, spend some time, get that polish all the way back up. If it's not polished well, it's going to wear much, much stronger against the opposing. Same if you have glazed zirconia and you remove some of that glaze, you got to go in there and polish that real well to get that shine back up. That'll help reduce the amount of wear against the opposing. And here is our prep when he started, and then there is our finished crown. And again, that should stay on there for a long time because of what we did with resistance retention form, and also by choosing the correct cement, which was the self-adhesive cement in this case, because we have such a nice long crown prep. So now let's talk about cementing zirconia. It's the steps that we want to do when we're cementing the zirconia. You're shining the crown in the mouth like we did, make adjustments. Sandblast the internal surface of the crown for about 15 to 20 seconds at 15 psi, or use Z-Clean or Ivo-Clean inside of the restoration for about 20 seconds, and then rinse and dry it. After that, you place some sort of a zirconia primer on the internal surface of the restoration for about 20 seconds, and dry it for about 3 to 5 seconds with air. Then you're going to mix your cement, place it on there, and seat it. Now, education is not the learning of facts, it's rather the training of the mind to think. So I'm hoping that we get into a little bit of a thinking mode here as I present to you my cementation tree of thinking. This is something that I present and spend a good amount of time when I teach live courses, but we're going to try to go through it here a little bit within our webinar. So stay with me, please, as you can, as we kind of try to go through it. And I know I don't have too much time left. You have a tooth preparation. Let's take this. Our tooth preparation is a short prep or has greater than 10 degrees of taper. Okay, you with me? So your prep is a short prep or greater than 10-degree taper. Not your most ideal prep, not a good prep, essentially. These could be your second molars, or in somebody who has a small mouth and you can't reach very well. Now we're going to look at what type of isolation you have, and that's going to determine what type of cementation you're going to have. So if we have good isolation, if the isolation is good, then I would use an adhesive cement, because now I'm not worried about causing isolation or causing sensitivity to a tooth like this. Secondarily, I would use a self-etch cement, and SE is down here, and so is RMGI, which is a resin-modified glass ionomer cement. So SE second, self-etch cement second, and resin-modified glass ionomer third. That's if you have good isolation. Let's say you have the short prep, greater than 10-degree taper, but your isolation is bad, and these people are just, you just can't get them dry, and they've got, those people that you look at them and they're just salivating just as they look at you. Well, in that case, I would probably use a self-etch, a self-adhesive cement first, just because I may lose a little bit of the bond strength that I would use with an adhesive cement, but then I'm a little bit less worried of causing sensitivity, okay? I hope you understand that. This is a very important part here. Tooth preparation, let's say you have an average prep. This isn't a great prep, it's not ideal, and it's not the bad short little prep that has less than 10-degree taper. It's just an average prep. Now you look at your isolation. If you have good isolation, then you can use a self-etched cement, you can use a resin-modified glass ionomer, or an adhesive cement if you really want the extra strength. I tend to say, if you don't need the extra strength, then just use a self-etched cement in a case like this, especially since you have good isolation. If your isolation is bad, again, this is somebody who has a lot of saliva, then you're going to use a self-etched cement for sure first, followed by resin-modified glass ionomer, and I probably wouldn't even use an adhesive cement on somebody like that, because this is an average prep and you don't need quite the bond strength there on your cement, okay? Now we go to the ideal prep. This one tends to be a lot easier, just because since you have an ideal prep and they have good isolation, you can use the weakest of the cements and the one that takes the least amount of time and the least amount to do, which is a resin-modified glass ionomer. Secondarily, you'd use a self-etched cement or an adhesive cement third. Remember, this is an ideal prep. Even zinc phosphate could hold these preps on for years. Let's say you have an ideal prep, but your isolation is bad. Again, it's an ideal prep, and resin-modified glass ionomers tend to do pretty well even in saliva situations, as well as self-etched cements. But I wouldn't put an adhesive cement on there because you don't need it and you don't want to cause any sensitivity. I hope that makes sense, and that's a really important thing to understand and really, try to use in your heads when you're looking at teeth and when you're getting ready for cementation. When you get this concept in your head, it really makes things flow a lot better. You wind up having a lot less sensitivity in patients, and you wind up really focusing in on what each tooth and what each situation truly needs. So in summary, let's summarize a little bit. Non-retentive zirconia restorations should be adhesively bonded, and retentive zirconia restorations could be cemented or luted with resin-modified glass ionomer or self-adhesive resin cements. I hope we made that kind of clear. Also, silane or hydrofluoric etchants or silica coating are not very effective for improving zirconia bonding, not necessary and don't work very well at all. The combination of sandblasting and priming with an MDP type primer is really the best way for treating the zirconia surface, the internal surface of your actual restoration. And then saliva contamination can significantly reduce zirconia bond strength. So remember that. The adverse effects of these can be removed, though, by either sandblasting or using some of those alkaline solutions that I mentioned previously. So you can use those to actually, once you've tried on your crown. We've got a couple of minutes left here. Let's talk a little bit about temporaries. So hopefully you don't run out of time too much. But you eliminate tooth sensitivity through fit and seal. I use things like cavity cleanser or Conceptus, which are chlorhexidine-based type items to help desensitize as well as killing bacteria. These help maintain tooth position. You keep ideal gingival health, and they allow you to use as a blueprint for patients. Patient feedback is great when you have large cases through temporaries. I show you most of the temporary materials nowadays tend to be the bis-acryl, bis-GMA type resins. There's a lot of them out there that work real well. I'll show you a quick clinical application. This is using a material called Template, which is from Clinician's Choice. This material sets in about 40 seconds or so. You place it on the quadrant or on the tooth. It sets very quickly. You can use these temp trays with it. There's a posterior and an anterior tray with it. place your material in there. This is a Structure 3 by Boco. This is a nano-filled, very quick setting, strong temporary material, and it has this wipe and go technology. When you're all done with it, you just wipe it up and the polish looks great without having to really spend much time polishing it. You take it out and you cement it. One of the things that we've been using that's fairly new is this Provocol QM aesthetic material. It's a translucent zinc oxide non-eugenol temporary cement, and it also has calcium hydroxide. It looks great, very easy to use, helps keep with sensitivity. I showed you there a posterior. Here's an anterior case we used with it, so it looks great underneath. And I'm going to share with you some tips on avoiding mishaps as I'm running near the end of my time. Pre-op articulating paper bite checks, I think we spoke about and you understand. Those are very good to use on all cases. Don't chase recession. If you have patients with a lot of recession in there, remember that these cements were made to adhere to tooth structure, whether it's dentin or enamel, and not so much onto root surface. I know sometimes we try to be heroes for our patients, but some of these cases where you have a lot of recession should be treated with a periodontist and gone that route. Make sure you have proper isolation. I think we spoke about that quite a bit. And also check your curing lights. Make sure that your curing lights are working. I spend whole sessions on curing lights at times, and we don't have time for that today, but please check your curing lights with an odometer. Now, a mind once expanded can never return to its original dimensions, Anne Hathaway, the wife of William Shakespeare, once said, and I hope I have expanded your mind in one way or another today after this hour they have spent with me. I know it was a lot of information, and I hope you stood in there and hung in there with me. I have a couple of minutes to look at your questions, and whatever I don't get to, please feel free to email me. There's my email, or you can even do it to my social media account as well. Trung, I'm going to look at the Q&As here. Let's see. And chamfer margin. Is chamfer margin the recommended margin for zirconia nowadays? In dental school, we were taught to do a shoulder margin. It can be. A chamfer is recommended. It can be. You can do a shoulder. That's fine as well. I just tend to worry sometimes in the anterior that margin can show a little bit. A chamfer tends to be a little cleaner. So you can use both. Just be careful where you use a shoulder. I think a chamfer tends to be a cleaner margin and it tends to show less and it's a little more aesthetic. Can you use hydrofluoric acid on the intaglio surface of monolithic zirconia is another question. No, that does nothing for it. If anything, it may affect the zirconia. Please do the sandblast or use things like the two items that I mentioned from Ivoclar or Bisco. Let's see, another question is, how hard is crown removal for a fractured crown removal for repair? What do you use to remove crowns safely? That's a good question. We didn't spend too much time on that. There are, especially for zirconias that are bonded, if you come across a bonded zirconia, there are certain kits that are out there that are, if you don't want to go through too many of your own burrs, some of these burrs tend to work pretty well. Shofu has a good one, and Clinician's Choice also has a good one where you can use some of these kits that are made to remove zirconia type crowns, and that way you don't have to go through 7 or 8 of your burrs to do it. Let's see. This lecture is so informative and well presented. Is there any way you get your PowerPoint to point for future reference? This will be up on the screen. So this particular webinar will be up for, I believe, 3 years at least, according to Trung there. And it will be up here on Viva Learning. Again, if you have questions, feel free to email me. I'm happy to help. Z Prime, you're asking, what is an MDP-based primer? MDP-based primer, one of them is Z Prime. That is a Bisco item. Let's see. Where are we? Great presentation. Thank you. I do appreciate that. How do you clean temporary cements? Let's see. I've got a few seconds left here. So I'm a big, there's a couple of different burrs that we tend to use. They're plastic burrs that tend to go around and just remove the heavier set. Depending on the type of temporary cement they use, hopefully you're using like the cement that I showed you is very easy to clean up. I have had cements that tend to leave a lot of material on the tooth. Sometimes I actually go in there and I just sandblast the tooth and clean it all up and make sure it's all nice and clean. I think that's the rest of my time. Thank you all. If I didn't get to your questions, by all means, please do email me. I hope you have a great evening, and thank you again for being with me.